We'll have 3 guides into our discussion today. We have Dr. Cynthia King, who is a board-certified adult and child psychiatrist, who has been a professor of psychiatry at UNM for 27 years. Her clinical interests have focused on serving patients with autism spectrum disorder and intellectual and developmental disabilities. She is the medical director for the New Mexico START program, which you'll hear more about today. We have Pat Osbourn, MA, certified speech language pathologist, who is the associate director of the Center for Development and Disability at UNM. She also directs the Autism and Other Developmental Disabilities program and is the program director for New Mexico START. In these roles, Pat builds and leads programs that are responsive to the needs of our disability community in New Mexico. And then we have Dr. Tiffany Otero, who is a licensed psychologist and the clinical director of the New Mexico START program. She specializes in the diagnostic assessment and behavioral health intervention for individuals with known or suspected developmental conditions. She began her career as a behavior analyst and special educator before pursuing her degree in school psychology with an emphasis in pediatric neuropsychology. So clearly a wealth of experience, wisdom, and insight with us today. And with that, I'll hand it over to the New Mexico START program team. Thank you so much for being with us today.
Thank you. We're so thrilled and excited to get to be here. I'm going to start first by sharing my screen. And I just want to make sure that you guys see 1 slide and not 2. I'm assuming you're seeing 2 slides right now. Okay.
Seeing 2 slides, now 1.
How's that? Perfect. Excellent. Okay, so we're here to talk about addressing the intersection of mental health and developmental disabilities through our integrated care model, which is the New Mexico START program. I will start us first with talking about the prevalence and the unique presentation of individuals that have ASD, intellectual disability, and mental health challenges. Then I'll turn it over to Dr. King, who's going to talk about some of the consistent barriers that we see to accessing care. And then Pat will talk about how we, as part of the New Mexico START program, use our approach to support these individuals through the challenges that they're having. We will reserve questions for the end, but feel free to chime in on the chat if there's things that come up, and I'll come back to those. So we'll try to end a little bit early so we have enough time for questions later. So no surprise that we are in the midst of a mental health crisis, definitely across our country, definitely across all demographics of individuals, but particularly in the area of autism. We know that autism is rising in prevalence. It's currently affecting 1 in 36 children in the US based on the last survey study conducted by the Centers for Disease Control and Prevention. 70% of these children also have 1 or more psychiatric conditions, and we will tease that out a bit more and look more closely at that statistic. Autistic people are 9 times more likely to experience suicidal ideation, and the mortality rate is about 2.5 times higher across all causes of death for autistic individuals. I also read a really terrifying statistic that for premature deaths or deaths that occur that are not due to old age, individuals with autism are around 31%. It's more 31% of those deaths for individuals with autism are by suicide, where by suicide for the general population is closer to 4%. So this is a very, very alarming statistic for us. And we also know that children with ASD are around 9 times more likely to visit to the ER for psychiatric problems than children who don't have autism. And I imagine that all of you who are practicing in the area of pediatrics and in the care that you are providing are possibly seeing individuals who are struggling as I'm describing them. So why is this happening? What are we seeing? What is giving cause to this rise in prevalence and in crisis event and intensity? I don't have a simple answer for that, but what we do as part of the START program is we try to look holistically at what is an individual experiencing and what are the challenges that they are facing, and where are those hot spots in their life that are resulting in propensity for crisis. So we use the biopsychosocial model to examine those vulnerabilities. And so you'll hear us reference that throughout the presentation today. And I'll talk primarily about the biological and psychological vulnerabilities. This is one of my favorite visuals for the diagnostic process, because as many of us know, while there are two domains of criteria that we assess for with autism spectrum disorder, specifically as a diagnosis itself, those being social communication deficits and the presence of restricted interests and repetitive behaviors. In order to do that effectively, we also have to assess the range of intellectual disability, language skills, and adaptive functioning or daily living skills. Also, as part of our work in diagnostics, we are looking and screening for those pink circles, which are the psychological potential co-occurring conditions, and then the green, which are the medical co-occurring conditions. And as you can see here, looking at this visual, it's an extremely complex process, not just for us as diagnosticians, but especially for the individual and their family who is encountering this variability for a diagnosis that for most of us sounds pretty common. And so what's really important to us is that we understand the nuanced presentation of all of our individuals and all of the additional complexity, both medically and psychologically, that they are encountering. Intellectual developmental disorder, you'll sometimes hear me flip back and forth between intellectual disability and intellectual developmental disorder. Intellectual developmental disorder is how it is identified in the DSM-5 text revision. So I'm still training myself on that. We do know it affects around 1.2% of the population, so it has a lower prevalence than autism spectrum disorder. However, about 39% of individuals with intellectual disability also have autism spectrum disorder. Of those with ASD, there is a range of intellectual functioning. Around 38% are identified as having intellectual disability at their most recent examination. Around 23.5% are classified in the borderline range, so they don't necessarily qualify for having an intellectual disability. But they're kind of on that cusp there. And around 38.6% are classified as having average functioning or higher. Another complexity in the diagnosis of ASD, of course, is communication. So we often see impairments in the realm of communication. And communication disorders aren't super uncommon for all individuals, affecting around 7.7% of children between the ages of 3 and 17. 63% of individuals with ASD also have a co-occurring communication impairment. And those can range from having absolutely no verbal language or having very few words or vocalizations, all the way to having the ability for complex language and having even sometimes very formal language where they talk like professors and instructors, but really struggle with reciprocity and really struggle even with their expression of their own thoughts and ideas personal to themselves. Something that's really important for us in our work in understanding crisis is, I don't know about any of you all, but when I'm in the midst of my own emotional dysregulation, in that moment, one of the very first things for me that goes is my ability to communicate what's happening, what I'm feeling, what's going on, what's affecting me. So my own communication capacity diminishes as a typically developing individual. This happens for most of us. It especially occurs for someone with ASD. So when we are encountering those individuals, and we'll often hear from families, they don't talk, they don't tell us what's wrong. Usually what's going on for them is that part as being affected for them, and they don't have the ability to. Psychiatric diagnoses and autism spectrum disorder are highly co-occurring, as we talked about before. Around 70% of individuals in a sample of those that have ASD have at least one psychiatric diagnosis. This is more often than those who have intellectual disability alone. So around 30% of adults and adolescents with just intellectual disability will have a co-occurring psychiatric condition. A range of around 10 to 60% based on the study for children and adolescents. Also, people with intellectual disability alone are less likely to experience suicidal ideation and suicide attempts than those with autism. So a lot of the things that we're seeing in terms of the crisis aspect of psychiatric conditions are disproportionately affecting those that have autism spectrum disorder. Around 40% of individuals with autism spectrum disorder also have 2 or more conditions, especially in our START sample, where we are seeing more people who are identified in clinical spaces referred to us from the hospital, or they are incarcerated, or they're coming from Texas Neuro. 95% of those children with ASD have 3 or more conditions. And so I'll often see a chart and I'll start to say, wow, we've got alphabet soup. We've got the alphabet soup presentation here, because that's where we're seeing they've got generalized anxiety disorder, they have ODD, they have bipolar disorder, all these things that have been identified as part of their chart. And some of what we do is differential diagnosis of trying to pick apart, well, what was an old diagnosis before autism was identified, and maybe what is a diagnosis that maybe is better explained by something else, or what are the co-occurring conditions that really truly do explain the breadth and the complexity of this person's presentation. Generalized anxiety disorder or other anxiety disorders are the most common psychiatric condition in autism spectrum disorder, affecting around 39% of those individuals. Another thing we see a lot in the crisis work that we do is the overlay and the interaction between trauma and autism spectrum disorder. So individuals with autism spectrum disorder are much more likely to experience trauma or have adverse experiences due to their communication difficulties. So they can't always describe what's happening that is aversive to them and can't get themselves out effectively. Their cognitive functioning also impacts their ability to understand why certain things happen. So some of you may be seeing this in the hospital settings where they can't conceptually understand why they're having to undergo a procedure or why they're having to be given this consequence. So it just adversely affects them. It affects them at the nervous system level to where then it has changes going forward for them. They're more likely to experience social ostracism, bullying, and significantly impacted by loneliness. Medical experiences tend to be, there's a whole paper about how to support someone who is undergoing a medical experience when they have autism, and how do we support them as providers. And then sensory experiences. I, as a neurotypical individual, generously speaking, don't have the same sensitivities as someone who has autism would, and therefore my ability to tolerate my environment is a bit broader. Whereas for them, lights, sounds, scents, textures, they're putting a lot of cognitive effort in regulating just that aspect. So anything that happens on top of that, their nervous system's already a little activated, aggravated, and so that can create a more impactful experience for them. They also have different perceptions of neutral experiences, and they may have a lower threshold of tolerance, again, because of the things I've described about their nervous system and the way it interacts with their environments. Their coping ability has a bit of a different space than maybe some of us do in a very similar circumstance. So again, we're helping others around them, their family members, maybe their other providers, maybe people at school, try to understand, okay, what is their relative threshold of tolerance for what they are experiencing in the school setting, and helping them understand it's going to look very different for somebody else in the classroom, or even for us to try to empathize with them. There's this great paper that just came out. It's a whole journal in the pediatrics of talking about the mental health crisis in autism. It's where got a lot of my statistics from today. And they defined a psychiatric emergency as a moment when, which is analogous to a mental health crisis. And it's an acute psychiatric or behavioral event that poses an imminent danger to oneself or others, in which the resources available to manage the event are insufficient to de-escalate the situation. And what we always describe to families in STAR, and the way we pare this down for them, is this: where there is an event where you do not have the tools to manage a situation to keep you and your family safe. And this can arise at school drop-off, this can arise at doctor appointments, this can arise over the dinner table. So we don't get to identify for them what a crisis event is. They tell us when they don't have the tools to manage something that's happening in their world. Common situations that result in crisis, and STAR, 100% of our individuals are referred to us because of aggression. We have yet to have an individual that does not present some way where aggression is not part of the picture. Depending on the definition in the literature, so, pawing at someone could maybe be identified as aggression in one paper. Actually making contact and causing physical injury can be a definition in another paper. That prevalence ranges from around 9 to 68%. It's associated with age and language ability. So people that have more impacted communication, where they can't speak as well, or they lose the ability to speak, tend to display more aggression or more externalized behavior. A lot of individuals with autism will also self-injure. That's around a 42% prevalence rate for those who are identified as having autism. That is also related to adaptive functioning, communication, IQ, sleep, sensory processing, impulsivity, and overactivity. So a lot of times we're asking about what is going on within their body when they are self-injuring, it's so that we can start to look at, are there possible medical etiologies for that presentation, for that behavior. Another thing that we got calls on when our crisis phone rings is a meltdown. So meltdowns are being identified much more specifically. These are an intense response to an overwhelming situation, resulting in a temporary loss of behavioral control that manifests verbally and or physically. These are very real experiences for the individuals that have them. I've had the fortune of being able to sit with adults that have experienced meltdowns and can articulate what a past meltdown would feel like. I've had them tell me it feels like you just Hulk out. Some of them describe they lose sense of memory. They don't remember what happened. It's sort of like a blackout for them. They lose sense of control. I've had a very articulate 7-year-old tell me that he's like, I can't be talked to, because it just doesn't go anywhere, it just falls. And so a lot of them talking about needing space. And so a lot of their behavior, a lot of their externalized behavior is in the function of getting away. And so it's very difficult for them to control, and very difficult for us to intervene on once they've reached this point. So with all of this that I've described, we have this sort of perfect storm for a crisis event. So at the very beginning, when I said, yeah, there's this mental health crisis happening, we can see that all of these components are coming together to create a situation where we are at a loss with tools for how to support them. So starting with challenges in conceptual understanding, communication deficits in emotional regulation, sensory processing, unmet mental health needs, lack of supports, and then that low zone of tolerance. These are all coming together to create events that we are struggling to address. It's not all bad news. We do know that there are strengths and positive outcomes, even just through the course of time. A lot of individuals, around 2/3 of individuals, will have a significant variability in their profile and their strengths and weaknesses, where they will have some, exceptional memory or exceptional vocabulary skills. So we can try to use those as sort of lily pads in our intervention process to help them build other skills in other areas that aren't as strong. We also know that through the course of time, most individuals make steady improvements from childhood to adulthood with consideration of a stable upbringing. So we will see reduction in symptom severity over time, just developmentally as their brain develops and they develop more inhibition. We'll see improvement in social skills. Many who are nonverbal will acquire some form of functional communication, whether it's through pictures or vocalization. Ritualistic or maladaptive behavior tends to reduce with age, and there are improvements in adaptive functioning and increased independence over the course of time. So I'm going to turn it over now to Dr. King, who will talk about some of the barriers that individuals with disabilities encounter.
Specifically to New Mexico, we have had a loss of psychiatrists and therapists and primary care providers. And so this is one huge barrier affecting access to care. Despite, as Dr. Otero said, functional improvements for individuals with autism as they age, and if there is a higher level of need, individuals with autism spectrum disorder report currently that there are increased barriers to mental health care. Many therapists refuse to treat individuals with ASD who are in non-crisis, and not actually always refuse to treat, but it may be related to insurance concerns. Another huge barrier is diagnostic overshadowing. And diagnostic overshadowing is when we misattribute a symptom of one illness to an already diagnosed comorbidity. So, for example, if we misattribute hyperactivity and school refusal to only ADHD and anxiety, this perhaps may lead to a misreferral for an autism evaluation. Or if we misattribute a diagnosis of autism to the above school refusal,
She froze.
interfere with best for individuals.
Dr. King, I'm sorry, you froze a little bit right after diagnostic overshadowing. Could you repeat again what you said? Oh.
I'm sorry, I've got muted again, sorry. So individuals with autism also report a lower satisfaction with medical care. They report there's a concern of increased risk of injury, and this may be due to behaviors being misinterpreted in the hospital setting, and or not being seen in a medical situation because of concerns of behaviors. There are also missed medical diagnoses due to behavioral presentations and communication impairments. The good example listed is when an individual is experiencing dental pain, but they're displaying self-injury or other directed aggression. So Another barrier to good outcomes is medication adherence. And as a psychiatrist, I think that certain medications can be life-changing. And one barrier that I've noticed often in clients I work with is the barrier of parents not knowing who or what to believe in as far as medications or prescribers. Many parents have seen children who've been over-medicated, who've lost their personality or zombified. And in these situations, they're unlikely to trust psychiatry or family medicine's recommendations for medications. So here is a nice slide about how poor medication adherence can be. And it's interesting, the highest adherence is with antipsychotics, and about 40% adherence is with antidepressants and ADHD medications. These predictors of adherence, or I think this may be non-adherence, significant predictors of non-adherence, may be or aggressive behaviors, abnormalities in eating, drinking, and or sleeping, co-occurring ADHD, and definitely the medication regimen complexity index. Another barrier for parents in knowing who to trust or who to believe occurs with different therapies or therapists. For example, applied behavioral analysis can be life-changing for individuals, especially in their developing years, and other different therapies recommended for children on the autism spectrum. But if a family has had a negative experience or had a poor experience, it's difficult for them to believe and trust that different therapies may be helpful. I think I wanted to put in a positive that even though we have lost providers, there has been an increased interest in, especially in psychiatry residents, of wanting to work with individuals on the autism spectrum, and also with individuals with intellectual disabilities. Okay.
And for that, we are very grateful, trust me. So that's a very exciting trend that's happening. So I'm going to talk a little bit now about what START does and how we kind of do it. I'm going to speak rather quickly. But really, when we think about START, we're thinking about systemic engagement with systems. And so although we work with individuals, we have individual participants who come to us because they're in crisis. We really look at all of the systems that are surrounding that individual, because often those systems are either in crisis, or they're non-existent, or there are strained relations, or whatever's going on. But we really want to look at engaging all of those systems. And that's really what the START model really believes can really support stabilization in the long run. So we collaborate with everyone who is actually in the community working with that individual. It could be a service coordinator, it could be inpatient folks, it could be prescribers, it could be whomever. But we look at the entire system. We also provide crisis prevention and specific intervention planning. We look for areas where we can develop linkages among agencies so that flow of resources can happen really quickly and easily. And then we look for opportunities for outreach. We really strive to build capacity, and that's probably one of our major focuses of building capacity across service systems so that people can really remain in their home and community. We are actually replicating a model here in New Mexico that was developed at the University of New Hampshire by Dr. Joni Beasley. It's been refined for about 30 years, and I believe it's in about 20 states at present time. These are some of the services that we provide, and we had to list them because there were just a lot that we were doing and we wanted people to really know. So we do limited crisis stabilization and emergency support. The limited is that we don't transport. That was one of the first things that we discovered when people thought of us. They thought we were going to transport people. We do not transport. But we do provide emergency support and stabilization. We have ongoing assessment activities with our participants. We do comprehensive service evaluation, cross-systems crisis prevention, intervention planning. We actually do clinical education team meetings and community trainings. We have weekly multidisciplinary consultation. I'm going to talk a little bit about our team in just a minute. We really try to facilitate and help with medical and psychiatric follow-up. We refer to resources, we do outreach visits, and just recently we have added therapeutic coaching to our menu of options, and we're pretty excited about that. I'll talk a little bit more about that. Okay. So really, kind of the model and how we really look at things is that if we can increase quality of life for our participants, we can decrease maladaptive patterns of behavior. And so our focus is really, you can go ahead. Our focus is really using a positive psychology lens. And positive psychology is really a very scientific approach. It's a human psychology field that really focuses on strengths rather than deficits. So our model is a total strengths model as opposed to deficits. Obviously, we have to talk about deficits because that's why we have participants referred to us. But again, we really work to improve the quality of life and well-being. That's really what we're hoping to accomplish. And we love this quote from Dan Tomasulo, who is one of our gurus in positive psychology. The absence of depression is not the presence of happiness. And I think that is pretty important to remember. Okay, so one of the ways we look at sort of this whole positive and how do we change a person's quality of life is through what we call PERMA Plus. And PERMA stands for positive emotions, engagement, relationships, meaning, accomplishment, and the plus stands for health. And so that's things like diet and exercise, nutrition, those kinds of things. But if you look at this, positive emotions really are things that bring us all enjoyment, contentment, amusement, anything that really helps us to feel good. Those are positive emotions. Engagement is that whole state of flow where we can be so immersed in something that we totally forget about time. We just kind of, we're just has our full attention and focus. Relationships, I think, are what all of us just have that is so very important is our trusted friends, our loving and close bonds that we have with people. Meaning really refers to having something that's really bigger than yourself, feeling part of that, and having something that's beyond your own personal gain. And then accomplishment is that satisfaction of achieving a goal, right? And even if it's a small goal, accomplishment is about achieving that goal. And when I look over this list, I think about my own self. If I had a week where a lot of these things were missing, non-existent, it would be a pretty miserable week. And it would actually become a pretty dark existence pretty soon. And when we look at many of our participants, as you can imagine, many of them don't have a lot of this. Their PERMA is pretty weak. They don't have a lot of positive things going on in their life. They may not have a lot of meaning or accomplishments, and sometimes relationships. So this is what we really this is the lens that we're looking at our participant and thinking about where we can beef up some of these areas for them. This is our clinical team and how we really do have an interdisciplinary team. We have a program director, that's myself. We have a clinical director, that's Dr. Otero. We have team leads who actually are overseeing all of our coordinators. We have a medical director who's Dr. King. And then we have our coordinators. Those are our boots on the ground people who are working directly with our participants. They're developing plans, collecting a lot of data, and really providing that primary crisis support. Our therapeutic coaching, we just have hired our first coaches, I think 2 weeks ago, they just began. And so they will be working directly with our coordinators to provide additional supports for our individuals in their communities. So that's exciting. So what happens when we get a referral? The first thing that happens is that we actually review the referral to be sure that they actually meet the criteria of what we are looking for in a person who is in crisis. Obviously, we have to have contact with the guardian and parent, especially if the child is not of age. We need that guardian and parent permission. We always screen for appropriateness. Is this a person who's truly in crisis? Is there something that we really feel we can support? We look at potentially evaluations if there is a need for diagnostic clarification. Many times our people do come to us with alphabet soup, as Dr. Otero said, or they come to us and people aren't sure if they have IDD or if they have a mental health diagnosis. It's all suspected. And then once we actually accept the referral, we assign it to a coordinator within 72 hours. The coordinator then begins all the work of collecting all the supporting documentation, doing assessments, developing provisional crisis plans, really identifying strengths in the system, gaps in the system, developing the cross systems crisis plan, and other plans that we develop. And then we begin the outreach with the individual in the system. So I wanted to just walk you through, and I'm going to do this really quickly, just so you get kind of a flavor of what we're doing. And this is a brief history of a young man named Mike. That's not his real name, of course. He was 17 years old when he was referred to us. He was actually one of our very first participants referred about a year ago. He was referred for aggression, property destruction, elopement. He left his house frequently. He lives with his mom and dad. He doesn't have any siblings. He hadn't been in school at that time for 3.5 years, a 17-year-old boy, 3.5 years. We found he had so many strengths, which was just wonderful. He was really a good problem solver. He really liked people. He loved people, loved to help others, loved to be around people. Really had a deep understanding of technology, which sometimes got him into hot water. And he really loved Sesame Street and Pixar movies. When we found this young lad, that's fine. When we found him, he was actually, I would say it was just this little unit. He, his mom and dad, and they were almost on lockdown. That's the only way I can describe it, because he left so frequently. They had to lock all the windows and doors, double lock them, because again, he was a good problem solver. He could always figure out how to get out. And all of the electronics in the house had to be locked. And so it was just kind of it was almost like a lockdown situation. One approach that we always take, and Dr. Otero talked about this, is really looking at that biological, psychological, and social strengths and vulnerabilities, so that we really get a very holistic picture of the individual. And we're not just looking at him as a behavior, because we could have looked at Mike as just a person who was aggressive and he eloped, and what are we going to do about this behavior? But we really, through a lot of tools that we use, we really take this biological, psychological, and social approach. And this is what we found with Mike when we kind of dug and looked at everything that was going on with him. In terms of biological, he has congestive heart failure and has had many surgeries as a 17-year-old. He had many as a baby, as a child. He has GERD. He has renal reflux, strabismus. He has a submucous cleft, which is repaired, but still some issues with in terms of intelligibility of speech. He has Hashimoto syndrome, and he has lots of bouts of constipation. Psychological, he has been diagnosed with post-traumatic stress disorder, primarily because of all of the hospitalizations and surgeries that he's had. And he also has a diagnosis as anxiety. Autism spectrum disorder was always suspected, but nobody could actually ever tease that out from the PTSD. And in fact, he'd been seen by many people with that question, and they would always go back to the PTSD and say, we really can't decide about this. And so that's where, again, we got into the diagnostic clarification. And Dr. Otero, our clinical director, was able to see him and was able to give that diagnosis ultimately. And so we do know that autism spectrum is actually one of his diagnoses. And socially, he becomes quickly agitated with changes in routines, new environments, and loud sounds. One of the tools that we use, and this really helps us figure out his systems and how they all interact, is called an eco map. And it really provides us a snapshot of how the different parts of his system actually relate and interact to support him. It guides our systemic consultation and informs us about how we can begin to develop plans. I'm going to show you Mike's in just a second, but you can see that this is the legend. If you see it, just a very single line, it's just a neutral or ordinary relationship. The thick line is really a strong relationship, and the dotted line has to do with strained relationship. The arrows have to do with the direction of resource, and I'll talk about that. So here's Mike. As you can see with Mike, he has a really strong relationship with his mom, and it's reciprocal. It's back and forth. Dad is not a bad relationship, but it's definitely not as strong as mom. But mom and dad have a very strong relationship. So you can see that this is really a little unit of three. There's some extended family, but you can see that line is broken, so it's strained. And the other thing just to notice is that all of his providers, those are strong relationships. He has a cardiologist, a PCP, he has a dentist. All of these providers are very strong. And all of the resources are going one way towards Mike, right? There's not that reciprocity in terms of what he's giving. You can see the officer down here. This is just kind of interesting because when he would elope, often 911 would be called and the police would show up, and he actually kind of liked that. The police officers didn't, but he kind of did. And so there's a strained relationship with the police department there. But you can see no relationship with school, no relationship with any kind of behavioral support. And DD waiver was really iffy. Okay. So again, another tool that we use. So again, to follow up with that, we realized very quickly that we had to make relationships with the school. That was like a first, right? And also help him get connected with waiver services and behavior support services. So those, because those were non-existent, that was something we had to do very, very quickly. Another tool we use is a cross-systems crisis prevention and intervention plan. This really assists our team in understanding the biopsychosocial understanding, really helps team understand vulnerabilities, strengths, informs the outreach, and it really provides a roadmap for crisis response and follow-up. This plan is one that we use to teach to the systems about all of the information we've collected and how it can support the individual in a crisis. It's a pretty long document. I'm just going to really quickly blaze through a couple pieces of it, just in consideration of our time. So part of our crisis plan is to identify some stages of crisis. And we understand this through talking with caregivers, through our own observation and other things. But we break it into stages so that people really understand what to do at each stage. So at stage 1, that's really our primary intervention. And that is just what you can do just right today, right now in your setting. And what we might see with Mike And what they do see with Mike is when he is beginning to be escalated, he'll start pacing. He might start perseverating on thoughts or ideas or things he wants. He might start breathing heavily. He might start gulping water or whatever it is that he's drinking. We think about this in the context of his personal vulnerabilities, which are his diagnosis of PTSD, social interactions, which are really rare and challenging and challenges with communication. Things that actually trigger him are things like being told no, having to do something he doesn't like, or removing an electronic device. And these are some of the interventions that we gave to mom and dad. Some of these were things that they told us worked, and some of them were things that we came up with. Okay, we can go on. Thanks. A secondary intervention, this is when Mike becomes a little bit more escalated. And at this point, he is cursing. He is starting to say things meanly to his parents. He's starting to throw things, and he might be continually asking for something. Usually he's triggered because he is being denied access to something that he really likes, or people are just, ignoring things that he really wants. At this point, again, we've given parents things to do, but we also give them our crisis line. And at this point, we tell them, call us. And at this point, the coordinator is usually on the crisis phone and talking to the parents, but also talking to Mike directly. And that's how we deal with many of our crises, talking directly to the individual using some of these techniques. Then we'll go to our third stage. This is really that acute crisis intervention. At this point, we are generally on the phone, and we're also in the car heading to the person's home, because we like to be present for these crises so that we can help de-escalate, but we can also then debrief about what actually happened. But we will start by being on the phone. And you can see with Mike, he begins to become aggressive. He'll hit, he'll break, a lot of destruction. The reason all of the electronic devices in the home were locked up was because he destroyed them all. And so that was a big trigger for him. Just a quick postscript, because we're running out of time. Mike has been with us now for a year. He's back in school, happily back in school. We had to work with the district to find a program that he felt comfortable with and that his family felt comfortable with. Part of the issue was that his family didn't trust any of the systems either. They had had a lot of negative experiences. But he's back in school. He's got friends. He actually has a little job that they've found for him, which is way incredible. He's sort of like a different young lad, I have to say. And it's pretty exciting to see the changes that have happened with him. He's doing so well in terms of stabilization that we're actually thinking about discharging him. Most of our participants are with us for a year to 18 months, and we will likely be discharging him. So he is really kind of a success story for us. So, all right. So this is our referral. If you would like to make a referral, and this is the criteria that we look at, we still are dealing with individuals who are within 2 hours of Albuquerque, because we like to be in person for crisis. And as I was saying, we like to be on the road heading over. But you can see these are people who've had a psychiatric admission within the past 24 months. They might be somebody who's in danger of maybe losing their place at school or losing in a group home. We have a lot of those individuals. Multiple different community placements. Sometimes these are individuals with just complex mental health needs. And those are the individuals that we are accepting referrals for. And so here's our referral line, and actually our email, which we will get back to, we absolutely promise. And this is just an echo that we're actually doing for advanced diagnosis. And we just wanted to be sure, we wanted to make sure that there were not any you who might be interested in this. This is actually, this is another part of our autism programs. We, as you all know, have a very long waiting list for evaluations. And so one of the capacity building efforts we are actually engaged in is called Echo Autism Advanced Diagnosis, where we are working with community providers to help them in this differential process. And of course, most of the differentials have mental health issues as well. So we just wanted you to be sure that you saw this as we're recruiting for a new cohort. And I think that's,
I'll leave the referral slide up, but yes, go ahead, Pat.
yeah, I think that is the end.
Wonderful. Thank you all so much. I really appreciate modeling in particular of strengths-based work, very compassionate care, and showing how to think of things really systemically and make interventions with that in mind. We have one question in the chat about autism evaluations for adults, which I know is a hot topic. I'm aware of a few places in town, and I can put those in the state, and I can put those in the chat, but I don't know if the speakers have any insights into that and maybe could share about the ADOS trainings the CDD is offering to empower our psychiatrists to make those diagnoses.
Do you want to, Tiffany? I can jump in.
Yeah, so what I typically, for anyone who's seeking an autism evaluation, regardless of their age, the best thing to do is just to have them go back to their insurance provider to see who's in network for them. We have short lists, we have folks, but nothing's gonna be really accurate without knowing what their coverage, what coverage is available to them. So the good news is we are expanding capacity through other providers in the state. And so hopefully there are folks that can do that for them. And we've heard people getting in and out of evaluations.
And I think the question was also services for adults. And honestly, we know that that is an area that is a tremendous need in our state. And it is an area that we are working on. We do have some programs for adults at our center. We have a Thrive program, which is for, it's almost like a kind of a transition program for young adults and actually not so young anymore, really to kind of launch them actually. And it has a lot of life skills and things like that. Yeah, and we also have a program called Partners in Policymaking. And often we do have adults with ASD who join that cohort as well. The needs are great though out there, and we're well aware of that, and are continually working on how we increase those.
And I have heard of efforts at the CDD maybe being offered like 3 times a year or so. That's free ADOS training. Do you all happen to know anything about those, or could say more? And that's open to all UNM psychiatrists, or what that process looks like?
Yeah, we've been doing them, I think it's 2 to 3 times a year. We actually offer ADOS training, and it's through Dr. Courtney Burnett, who's running our ECHO programs. She is actually a certified ADOS trainer. And so, she's the only one in our state. And so we will be doing another one. It's already scheduled, and I want to say it's in February or March. And that ADOS will actually be getting us ready for our new cohort in the advanced diagnostics. So yeah, but I know we just did one actually in the fall. It's not really fall, but you know what I mean? We did one just a couple of weeks ago. So we'll do one in the springtime again.
Perfect. And just to remind general psychiatry colleagues from the child psych world, since we often get to see more autism and intellectual developmental disabilities, is that psychiatrists can diagnose autism. It's a clinical diagnosis. With the ADOS diagnosis, that does open up some other resources and avenues for patients. But just to encourage folks with the right training, you too can be a much needed resource for adult patients.
Yes. Yes.
And you mentioned, oh, go ahead, Dr.
No, I want to, and this provider knows who they are. I won't identify them, but they're here, and I just had an amazing opportunity to work with one of you all, and they made the diagnosis, and we were able to complete the comprehensive diagnostic evaluation through the START program. And so that helped fast track that process so that we could facilitate opening up more opportunities for them. And so, yes, absolutely, we can collaborate, consult, and that was so well appreciated. So thank you to you for your engagement with that, because that did help open up the doors for this individual in the diagnostic process and in the intervention.
Wonderful. Really appreciate both in the presentation and what you just shared, Dr. Otero, as far as those models, I think is huge for learning. Speaking, you mentioned the Echo Pad, and Dr. Grace in the chat asked about specifics of the date times of the Echo.
Right now it is, it's twice a month on a, let's see, I'm thinking the advanced is on Thursday. Yeah. Yes. And so we just did one yesterday, so there'll be another one in 2 weeks. So that's how it goes. And it's from 12:30 till 2 o'clock.
Thank you.
And if you'd like to join, honestly, you could get in touch with Dr. Courtney Burnett, or you can get in touch with us and we can get you in touch with her, because I think that it would be great to have some psychiatrists there. We would absolutely love that. Yeah, please. We would love that.
Thank you. Well, thank you again for all this information today and what y'all do. Yeah.
Another question here about an age limit for the START program. There is not currently an age limit for the program, just the bottom age limit being age 6, but we're seeing our eldest right now is 67. So yeah, that's been an exciting one. And what's nice about the collaborative work we do, I mean, I'm a pediatric trained psychologist, so it's definitely outside of my scope, some of the things that this individual's encountering, but because of the collaboration, we can support this individual in accessing services. So we can consult on the neurodiversity component, but still advocate that this individual receive geriatric services appropriate for their age and stage of life. And yes, I'm happy to provide our presentation. I'll send handouts over to the facilitator, so that way you guys can have access to these.
There were a couple more questions. We talked about services for adults with autism. It's escaping my mind at the moment, but I bet someone here will know. There's another service at UNM that's available for consults, but it's sort of a one-time consult for adults with autism. Can anyone share the name of it? I think I saw it.
TESC.
Yes, thank you.
Oh, yeah, of course, yes.
Awesome. Thank you, Dr. Gonzalez. Yeah, that's one resource that's available as well. And then Dr. Ortiz asked, how do you all feel about non-autism experts diagnosing autism?
It's a big question.
I'm sure as most experts feel.
I mean, so, there's, with the range of presentation, there's the obvious presentation. So one of the echoes is not the advanced diagnostic component. It's for physicians to diagnose very clear presentations of autism using something called the STAT. And so there is a battery that is very baseline. It's observation, records review, diagnostic interview. That's enough for a clear presentation. So it's not really about, do they have to be an autism expert? It's, have they had the required training to be able to identify a presentation within their scope. Mm-hmm. For more nuanced presentations, I would advise someone or a provider to say, let's look at another level of diagnostic expertise for this presentation. So, here at the center is a good example. We have multidisciplinary clinics, but then we can also we're working on a clinic to incorporate psychiatrist involvement with us, so that way we can look at the neurodiversity side as a psychologist can do that, but a psychiatrist colleague can consult with us or be present with us to help us look at the psychiatric component more broadly. So it's, I'd say if you have the training or if the person has the training, I'm about it. We want to expand the services and access for these individuals.
And that is why we are putting so much effort into capacity building, because no one organization can do it all. And this is a nationwide problem. everybody has wait lists like we do. And so that's why we really did do kind of a mid-range adjustment and say, we have to really put effort into capacity building. We've got to rely on community providers, physicians, psychiatrists. We have to rely on that because nobody can do all of this, with a prevalence of 1 in 36. It's a different world now. Yeah.
We're out of time. There were a couple unanswered questions in the chat. Would the presenters be open for folks contacting them if they have any other follow-up questions?
Of course.
Perfect. Okay. Well, thank you all so much for attending today. Big thanks to the New Mexico START team for your work and supremely informative presentation today. Hope you all have a good rest of your Friday and a good weekend. And don't forget your CMEs. Robin has posted in the chat. Take care.
Much.